We are back from the break now, so I think we are running a little bit late because of the technical problems we had at the beginning. So, so it was candidate three with me until now, isn't it?
I think
So
I'm
now,
correct. Yeah.
it's candidate four.
Yeah. Hi.
Yeah, hi. So now, yeah. So we are now going to look at the admixture lesions, okay? So before we actually go into the cases, let's have a look at how to approach an admixture lesion. So essentially, the basic sequences that we need to have are a T1 weighted, T1 fat saturated, T2 weighted, and T1 post-contrast images. For many of the pathologies, you may not require a T1 fat saturated sequence, a T1 post-contrast sequence, but the diagnosis may be can be confirmed with T1 weighted and T1 fat sat and T2 images. So a simple cyst would be low signal on T1, low on fat sat, bright on T2, and will not enhance. A hemorrhagic cyst will be bright on T1, it will remain bright on fat saturated, it will be bright on T2, and it will not enhance, it will remain bright on the fat saturated image. An endometrioma will be bright on T1 and remains bright on T1 fat saturated, will be of low to intermediate signal on T2, and it will remain bright on the fat saturated image. There will not be any enhancement. Whereas a dermoid, because of its fat content, it will be bright on T1 and it suppresses, becomes dark on T1 fat saturated image. It doesn't mean that the entire tumor, entire lesion has to become dark. It's only the fat component that gets suppressed and become dark. And T2 weighted, it is of intermediate signal and it will not enhance. Whereas a cystic neoplasm can show low signal or intermediate signal on T1 depending on the protein or hemorrhagic content that will remain so on the fat saturated image. It will have solid component visible on the T2 with bright surrounding fluid, and the solid component will enhance on post-contrast image. So this T1 fat saturated images are very crucial in coming to a conclusion. Okay. Yeah, candidate number four. This is a 25-year-old female, has a pelvic mass. Now, describe your findings.
So these are several axial slices of an MRI pelvis in a 25-year-old female with a pelvic mass. In the top image is
Okay. Before that, I would like you to identify the sequences.
yeah.
So what am
So,
I pointing at?
so I believe that is T1.
T1 axial, good. And what is this?
That is T2.
How did you say this is T2?
I think there's high signal. Oh, sorry, that's low. I'm sorry, there's low signal in the uterine cavity, I think.
There
So,
is a bright signal of endometrium, and you can see bright signals of ovarian follicles.
okay.
Okay, so look everywhere else for some clues. There might be some free fluid which is bright, endometrium, urinary bladder, bright T2 follicles. So they're all giving clues as to this is a T2.
Yeah.
And this
So,
is a
and this will be a fat cell.
fat suppressed image. And here we have a fat suppressed T1P pre and post contrast. Okay, yeah, continue with your findings.
Yeah. So there is a mass lesion anterior to the uterine cavity with
Mm-hmm.
mixed signal on T1 and on T2 as well. There are areas of high T1 signal within a flocculated area in the left side of the mass itself. There
Good.
appears to be a fluid level, and
Mm-hmm.
there's an area of low signal intensity in the superior aspect as well. Moving on to the center image in the top row, the areas which were low T1 signal demonstrate high T2 signal,
Mm-hmm.
um, which will be in keeping with our fluid. And
Mm-hmm.
in fat saturation, um, I note that The superior aspect of the loculated left side area suppresses, indicating it is fat.
Okay.
And in the post contrast fat side images, there's no significant enhancement, I think.
Good. So your diagnosis is?
So putting these together, I think this is a large, well, because of both fat content and fluid content. Um, I was thinking this could be a dermoid cyst, but not 100% sure. I think it is, yeah.
It is a dermoid
Yeah.
cyst. So if you identify fat signal within adnexal lesion that doesn't show any enhancement, the fat is, we've confirmed it is fat because it's been suppressed on the fat suppressed image. You can confidently say this is a dermoid cyst or a mature cystic teratoma.
Yep.
Okay. So you've described it well. So here we have a multicystic, a complex adnexal mass, which has got predominantly low signal in T1 with focal areas of high signal, which is getting suppressed on T1 fat saturation. On T2, the subfat remains intermediate signal, the rest is showing fluid signal, and there is no enhancement in the post-contrast image. Another thing, if you're just given one post-contrast image, how will you say it is a post-contrast image? For that, again, look at the uterus. Uterus myometrium will enhance, and you remember the trilaminar zonal anatomy that you see in a non-contrast T2 image. Here you can see the myometrial enhancement. Okay, so this is another case of a dermoid, which is another complex mass which was seen on ultrasound. We can see there is fat component which is getting suppressed on the T1 fat saturated images. So this is a T1 bright signal getting suppressed on T1 fat saturated. And so this is again a dermoid cyst. So if you're given this image alone, how would you say this is a T2?
So I think there's some fluid within the endometrial cavity, which is sort of
there is. So this could even be the bright signal of the endometrium. Okay. So yeah, or fluid. So yeah, that's how you look for clues in the image. So sometimes you may not have anything. Look at the spinal canal. You may see fluid within the spinal canal. You may see a little bit of bladder somewhere. So look for clues as to identify the image. So sometimes you may be given an X-ray, and what is your finding here?
Okay, so this is a frontal radiograph of the pelvis, partially imaged, of a 25-year-old female with pelvic discomfort. I note that there is a control, image, and there appears to be calcification or rather high density in the central part of the abdomen. Given the pelvic discomfort, the calcification probably denotes elements of a dermoid cyst. So that was my first differential.
Okay, yeah. You can actually, if you stretch your imagination, you can actually see that this looks like a tooth-like configuration. I don't know if it's that clear on your screen, but yeah, yeah. So in a female, if you see this kind of dense calcified opacities, you have to think of dermoid in the differential. And yes, CT did show a dermoid with calcification and fat density. Now on ultrasound, you may never know, you may be given an ultrasound image of a dermoid. So on ultrasound, it can have varied appearances. So it can be diffusely or partially echogenic. Because of the presence of floating hair and sebum, it can have areas of posterior dense shadowing. And here you can see peripheral dense nodule, a peripheral dense, echogenic, not dense, a hyperechoic nodule in the periphery with posterior shadowing. So this is called the dermoid plug or the Rokitansky nodule. So this is another appearance where you get multiple dot and dash of hyperechoic foci. And to the bottom right, you have a floating ball appearance, which is the least common, but if you're shown that, it is 100% pathognomonic for dermoid cyst. Okay.
Okay.
So Chapman gives a differential for unilocular cyst with internal echoes, and these are the differentials. We have covered dermoid cyst. We've seen corpus luteal cyst. We will look at some of the other pathologies as well. Yeah, candidate 4 again. So this is a 48-year-old female, sudden onset of right iliac fossa pain. So she had a CT scan.
Okay, yep. So these are three representative images of a contrast enhanced CT, two axials, and a coronal image. There is a fairly well circumscribed lesion in the right adnexa with areas of mixed densities, which are in keeping with fat and calcification and soft tissue. On the contrast enhancement, there's rim enhancement around it and surrounding fluid density material. And this is in continuity with the uterine region as well. And there's free fluid on both sides of the pelvis. So I think this is in keeping with a torted ovarian, a dermoid cyst or ovarian cyst. Differentials include hydrosamplings, but less likely.
Sorry, what was your differential?
Possibly a hydrosalpinx or a ectopic pregnancy as well as possible, but I think my top differential will be a dermoid cyst which has torted.
Okay. Okay, so this is a torsion of an ovarian dermoid. So if you're saying a hydrosalpinx or any other things, then how would you explain the fat density there? So you've already identified a lesion, adnexal lesion containing calcification and fat, and that is a dermoid cyst. So there is no other differential here, especially when we are not seeing the convoluted tubular pattern of a tube. So the differential of hydrosalpinx will not come into this picture. Okay. So if you have seen an adnexal mass and you've identified it as a dermoid cyst, and if it shows, and with the history of sudden onset severe right iliac fossa pain, and if it shows adjacent fat stranding and significant fluid, then that is sufficient to call it a torsion of adnexal mass, torted dermoid cyst. Now, the other differentials of right iliac fossa pain will be there in the clinical differential like appendicitis. So we have in one of the cross-sectional images, we have a normal looking appendix. So anyway, this was a torsion of dermoid cyst or adnexal torsion. This has been asked, repeatedly asked, so it's important to be familiar with this appearance. Okay, good. So the complications of dermoid cyst are torsion is the most common, followed by rupture. Malignant transformation and infection are rare complications. The dermoid can have thyroid tissue within, so that's called struma ovary, and in which case it can develop hyperthyroidism. There's a possibility that it can develop hyperthyroidism. So this is a case. The lady presented with sudden onset severe right-sided abdominal pain and an abdominal mass. So this was the first imaging that we had. So we can see a large mass, abdominopelvic mass extending from the pelvis into the right side of abdomen. It has got very clear fat containing fat densities. And so this was diagnosed as a dermoid cyst, and malignant change was suspected. Considering her severe pain and the presence of a fluid, we also gave the possibility of torsion. This patient worsened, deteriorated in the next few hours, and follow-up CT scan showed that the entire mass, which the solid component had now become necrotic, the lesion had enlarged, more free fluid, and if you actually look at the series 2 axial image, you can see fat density outside the main tumor within the ascitic fluid. So this is in keeping with a rupture of dermoid cyst. And soon she developed superadded infection as seen by peripheral enhancement and presence of air. So this lady had all complications that can happen to dermoid. So, but we couldn't confirm if there was any malignant change actually associated in this case. So if you are given a case of dermoid, and if you can confidently see fat density outside the tumor within the fluid, that is rupture of dermoid. Yeah, candidate 4 again.
Yep, so these are representative slices of an MRI scan. The top left image is a T1 image, which shows a high signal intensity lesion which is fairly well circumscribed in the left adnexa, more towards the pelvis, in the towards the rectum rather. And in the second image, there's a fluid level.
What is the second image? What sequence is it?
So this will be a T2 with the fluid
Okay.
level, with the highest signal being the upper part of the fluid signal.
Mm-hmm.
And in the last image, it's a, I think this is a T2 surgical
Good.
as
Yep.
well, which shows some increased low signal intensity in the inferior aspect of this lesion.
Mm-hmm.
So this is a cystic lesion with 3 different signal intensities. Um,
What is your diagnosis?
so I was wondering if this is an endometrioma.
Okay, so something was missing in this. You are right, but something was missing in the sequences that I gave. If you have seen
Yeah,
something hyper intense on T1,
or like a fat
what
set.
should you ask your examiner for?
Like a fat set image and
Exactly. So
contrast.
a fat saturated sequence was missing. So here you go. So now,
So in the fat saturated image, the low T2 signal is it's a high it's high signal basically, so it is not fat and slightly blood, and this will be in keeping with a endometrioma.
good. So this is an endometrioma. Um, yeah. So endometrioma. So let me go back to the slides. Endometrioma, because of repeated cyclical bleed. So it is a hemorrhagic lesion. So it will be bright on T1, remains bright on fat saturated image. And on T2, it will be of low signal. We'll come to that. And this appearance is called T2 shading. And these features all fit with an endometrioma. So what do you mean by T2 shading? T2 shading is actually the inherent low signal or the reduction in signal on T2 weighted images within the endometrioma when you compare it with T1. So on T1, if it is bright signal and T2, it is low signal, low or intermediate signal, then that appearance is called T2 shading. T2 shading, it heavily depends on the amount of protein and iron content within the endometrioma because of repeated cyclical bleeding. And it can have various appearances. It can appear as a fluid level, or it can appear as a homogeneous low signal lesion, or as a gradient loss of signal. Now there is another sign which is the T2 dark spot. So in the periphery of the endometrioma, close to the wall, you can see very low signal foci within the lesion. So these are hemosiderin-laden macrophages which have accumulated over repeated cyclical bleeding. So this is another sign you see in an endometrioma. So although this is the T2 shading is a very sensitive sign, you have to remember that it's not specific for endometrioma. You can have T2 shading in other hemorrhagic cysts which have undergone repeated bleeding, or in some hemorrhagic ovarian tumors which again have repeated bleeding. Yeah, candidate 4, I think you've covered the previous dermoid pathology as well, isn't it? So I think we'll move to the next candidate. Candidate 4,
Thank you.
thank you very much.
Hi.
Hi. This is a very interesting case. I've taken it from Radiopedia. I'll help you a little bit with this. This is T1. The first top two are T1 images. This is a T1 FATSAT. This is a T1 post-contrast. And the rest are all T2 images. Now, can you describe the findings? There are a lot of findings here. Describe the findings.
So I can see on the top images that there is on the T1, there is a hypointense with a central hyperintensity anteriorly. And then going on to the next, which is a T2.
This is again a T1.
Oh, sorry, yeah, the T1. it is bright again, and it looks like it's a multi-septated lesion.
Yeah.
There's no solid nodule at this stage that I can see. And then as I go on to the further images,
Fat saturated T1.
on the fat sat, it remains bright. So bright on T1 and then bright on the T1 fat sat. And then I think I've got the post contrast on which some of the elements show avid enhancement. The central stroma, what I could call, appears iso-intense, but some of the ovoid elements show enhancement more than the central.
What is the enhancing part, the central stroma that you call? What is that structure? That is actually uterus. That's a uterine myometrium that is enhancing.
Okay.
Okay, that's a uterine myometrium.
Then the next sequence, I can see 2 endometrial cavities.
Good.
Yeah.
Good.
And then in the lower on the lower slices, which are all T2, I can see that there are bilateral, on the coronal, there are bilateral adnexal lesions, well defined. The one on the right appears iso-intense, and the one on the left has a single septum, no solid elements, but again is hypo-intense to iso-intense. And no abnormal intermediate signal within the uterus in the first 2 images. But I could see the 2 cavities. If this is part of the same patient, then I cannot see the second cavity on the lower slices.
Okay, don't worry. In the lower slices, I should have explained it better. I have given serial coronal images. This is from the back, posteriorly, and coming forwards. So as I'm coming forwards, I can see the first uterine cavity, again the same uterine cavity, and it's sort of ending here. And in the anterior-most image, I can see suddenly a second uterine cavity.
Okay.
So,
so it isn't behaving like a simple cyst, these lesions, and is behaving like blood on the fat sat sequence.
Okay, so look at this T2 sagittal. What is that? Looking at the tubular structure, what comes to your mind?
The fallopian tubes. I was thinking whether this is hematosalpinx on both sides.
Good. Hematosalpinx is there, and you have an endometrioma.
Endometrioma, with the shading sign.
Let me show you the case in the PAX model. So this is a case of a right uniconvate uterus with non-communicating functional left horn with hematometra. This is hematometra. It's bright on fat saturated and it's bright on T1. With hematometra, hematosalpinx, and endometrioma. Remember what we discussed during our Muller induct anomalies. The type 2B classification, that is a uniconvate uterus with a non-communicating but functioning endometrial cavity is more prone to have endometriosis, endometrioma, and they'll have hematometra, hematosalpinx because of retrograde menstruation.
Yes.
So I'm going to come out of this presentation and I would like to open a PAX model. Can you see the slide saying right uniconvate uterus?
Yes, I can.
So now it's in the PAX model. So we are looking at the coronal. You focus only on the uterus for the time. So you can see as the uterus goes and as the uterine cavity finishes, a second uterine cavity appears. Okay. Now I'm coming back down again. Now look at the adnexa. You can see a normal right ovary there. You can see that it's on the left side, it's a normal right ovary. So this is the left side hematosalpinx, which ends in a endometrioma. So which is the sagittal. So as in the sagittal, you can see the nice convoluted tubular hematosalpinx and 2 separate endometrial cavities not communicating. Okay, and on axial T1, you can see an incidental small hemorrhagic follicle within the right ovary. You know that the normal cavity does not have blood within. The hematometra is within the non-communicating rudimentary horn.
Okay.
So, and this appearance of multicystic structure, it was more clear that this multicystate area was a tube, which we actually saw on the sagittal images. Axial fat sat confirms that it is blood. Okay.
Yes.
So it is going to come out of it. This is a very nice case showing the complication and importance of properly classifying it into the type 2B unicornate uterus. So coming back to my original presentation. Can you see it now?
Yes, I can see the case that you showed me. Yeah.
And now I'll go on the slideshow. Yeah.
Can you do the slideshow mode, please?
Yep. It's in the slideshow mode now, isn't it, Dr. Khan?
Yes, it is in a slideshow to me now. Yeah.
So endometrioma, this is the classical appearance on ultrasound. So where you can see a unilocular cyst with packed low-level echoes, so sort of a ground glass appearance. Okay, so it will not have any internal vascularity. It will have good posterior enhancement. Sometimes you can see peripheral hyperechoic focus towards the periphery in an endometrioma, and you have to differentiate it from an dermoid cyst, which will show posterior shadowing.
Yeah.
Okay. So yeah, have a go at this case.
So again, I've got multiple slices of the MRI for pelvis. So the first is a T2 because the urinary bladder is bright. The next, on which I can see there's a bulky uterus.
You mean this image?
Yes.
And so this is a posterior structure that is in the pouch of Douglas. So this cannot be bladder.
Oh no, this can't be bladder, sorry.
So there is a bright T1 bright lesion in the pouch of Douglas.
Okay, which is bright on T1. So the next sequence is then a T2, on which I can see that the bright structure in the posterior compartment is iso-intense. So bright on T1 and iso-intense on T2, and stays bright on the fat sat sequence, axial slices, and then so it's behaving like blood and is in the posterior compartment, posterior to the uterus. It's a bulky uterus. Then on the sagittal sequences, again, it confirms that this is an T2 iso-intense signal lesion posterior to the uterus and is separate to the uterus. And the uterus is bulky and has fibroids within it, subserosal. I cannot see any solid elements. So I'm thinking whether, because it's posterior, it's behaving like a hemorrhagic cyst.
Okay.
But it is not in the right location.
No, you can
for it to be an ovary.
If you have endometrioma, you can have ovary anywhere, isn't it?
Yes.
It doesn't have to be a textbook like it can be positioned in the pouch of Douglas anywhere. So if you're seeing in the pelvis or in the right or left or in the pouch of Douglas a lesion like this, then without any solid components, be confident you can call it an endometrioma. And we are seeing the beautiful T2 shading in this case.
Yes.
Okay. So, and when you describe the uterus, you did say uterus is bulky. So what's happening to the junctional zone?
So there's a widening of the junctional zone. I cannot see the classic T2 high signal suggestive of adenomyosis, but widening of the junctional zone would suggest an adenomyosis.
Okay. So there is diffuse widening of the junction zone. This is adenomyosis. And as you rightly pointed out, there is a subserosal fibroid. If you go back and look at the T1 weighted image, you can see a tiny high signal focus within the myometrium, which stays bright on the T1 fat sat. It's very tiny. So that is a tiny microhemorrhage that again is in keeping with adenomyosis. Okay. So Good. So this is endometrioma, adenomyosis, and serosal fibroid. So this is a case of chronic pelvic pain, and the patient presented with melena and hematuria.
So on these selected slices, so the first one, again, I take to be the T1 axial slice, and then T2. So I can see there is a cystic structure anteriorly, which is low on T1, bright on T2, and then on the T1 fat sat, it stays, it's not as bright as blood, but is brighter than, as iso-intense to the muscle.
It is showing intermediate signal on T1.
Yes.
And on T2, it is bright, and because the fat elsewhere is suppressed, this looks bright. So this is sort of showing a blood-like signal.
Yes.
Okay. Okay. Yep.
And then on the lower sagittal sides, I can see there is abnormal hypointense signal arising. I'm wondering whether this patient had previous surgery.
What surgery?
Because I can see the vaginal vault. Whether they've had a hysterectomy?
Yes, good. So the patient doesn't have a uterus. She has had a hysterectomy.
And I can see the vaginal vault.
Yep.
But there is abnormal signal, T2 signal projecting posteriorly, which is enveloping the urinary bladder posteriorly and extending through to the vaginal vault. And a patient presenting with chronic pelvic pain, now I'm thinking whether this is endometriosis.
Well done. Excellent. Yeah, good. So yes, this is endometriosis.
Yeah. So on the coronal image, then again, which shows the endometriotic bands, and on the post contrast, I can see there is contrast enhancement anteriorly within the tubular within the cystic structures that I saw, but not in the one on the right side. The one on the left side enhances uniformly.
Okay. Okay, good. So this is endometriosis, and as you rightly said, anteriorly you can see a cystic structure with evidence of blood. So this is endometrioma. Actually, on the coronal slice, you can also see an endometrioma in the right groin. Now, more importantly, this shows extensive endometriotic plaques within the pelvis. Endometriotic plaques typically on T2 are of very low signal. Okay, so characteristically, these are very low signal, and they cause adherence. I mean, the bowel tethering of the bowel loops. They cause speculation, and the most common sites of involvement are posterior bladder wall. Now, I'll go to the next slide, so that will be more clear in that. Yep. So deep pelvic endometriosis can be superficial, deep, or ovarian endometrioma. Okay. Superficial implants are very small and you cannot find them on MRI. Whereas deep pelvic endometriosis, these plaques appear typically low signal on T2. Okay, you may see tiny cyst-like foci within this endometriotic plaques, which are dilated endometrial glands. They can have speculation. Now, be aware of the most common sites of endometriotic plaques. So the posterior surface of uterus and the posterior fornix, and these are the favored sites for endometriotic plaques. Now this is where the uterosacral ligaments attach. So that's again another common site. Uterosacral ligaments are again a favored site. Anterior rectosigmoid. There are serosal deposits at the anterior rectosigmoid. Posterior bladder and abdominal scar, cesarean section scar. So these are commonest sites of endometriotic plaque deposition. So once you know how an endometriotic plaque looks like, and once you know where to look for, then the diagnosis becomes easy. So now on this case, we can see a dense, thick, low signal endometriotic plaque draping over the posterior bladder wall. Again, from the posterior fornix, you can see plaques extending, and there are deposits on the serosal surface of the sigmoid. So that is typically low signal. So this is an appearance which is called the mushroom cap sign. The base of mushroom is the T2 low signal plaque, whereas the outermost part of the cap is formed by intermediate to bright signal of the submucosa and mucosa of the bowel. So what happens is when this deposits on the serosa, the bowel wall is actually displaced more towards the lumen, and so the outer signal, bright signal, is formed by the submucosa and mucosa of the bowel. So this is called mushroom cap sign. This is again a case where you can see multiple endometrioma, not suppressed and still looking bright on T2. We can also see a hematosalpinx element, which is a convoluted or a tubular structure having blood signals. Whereas when you look at the uterus, you can see there is endometriosis by diffuse thickening of the junction zone and dense plaque along the posterior surface of uterus. The rectosigmoid is quite adherent to the uterus. Okay?
Yes.
So now we know where to look for to diagnose endometriotic plaques. This is a case of endometrioma and endometriosis. Can you describe the top two images? Can you describe the appearance of the endometriotic cysts here?
So again, I've got a coronal T2 and adjacent a coronal T1 with contrast.
This is
or just a T1.
That's saturated image.
That's so. So on the T2 image, I can see the uterus appears unremarkable, but I can see superiorly that there are two cystic structures, isointense on the T2, and they have no solid elements, and cannot see any abnormal T2 signal extending.
So we know these are endometrioma. So what kind of, does the appearance ring a bell? I mean,
is this the kissing?
Exactly.
Yeah, kissing ovaries. Kissing ovaries.
Kissing ovaries or kissing endometrioma. So what happens in case of endometriosis or in pelvic inflammatory disease, there are a lot of adhesions happening in pelvis. So that actually pulls the ovaries or the cysts more towards the midline. And so they are called kissing cysts.
Yeah.
Okay. And again, we can see the T2 shading here, which is of a gradient in the loss of signal. And again, we can actually see the endometriotic plaque, which are not as extensive as in the previous case. We can still see them causing adherence of this endometrioma to the posterior surface of uterus. You can actually see tiny cystic signals within that plaque. On this, you can actually see it better. You can see adhesions extending towards the rectosigmoid from it, and that's more evident on this case. So again, I say once you know where to look for endometriotic plaques, then the diagnosis becomes easy. Again.
So again, I can see that on the first axial slice, which is a T2, I can see a T2 hyperintense area in the right anterior abdominal wall, and then which on the sagittal image, it's the sagittal, which is again a T2. I can see a dark T2 hypointense dark band there, and further lower down I can see the same signal on the sagittal. So this is a endometriosis in a scar tissue.
Good, that's good. This is scar endometriosis. So as you rightly said, so within the abdominal wall there is an intermediate signal soft tissue lesion. Which does have tiny foci of bright signal on T1. Okay, and we can still see tiny foci of signal on the fat suppressed T1.
Yeah.
The lesion is dark on T2. It does show some tiny cystic structures. It has some spiculations. So this is in keeping with an endometrioma, scar endometriosis, and this is a tiny microhemorrhage. So actually this slice of uterus, we can actually show the lower segment cesarean scar, which is actually a clue as to this is a scar endometriosis. This is a lady who has a known endometriosis, endometrioma, bilateral endometrioma. You can actually see a hematosalpinx component on the right side. So she presented with acute or chronic pelvic pain. She was very unwell and febrile. So can you describe the findings? So we already know that she has known bilateral endometrioma and a small hematosalpinx on the right side. So maybe you can describe the bottom 3 images, or the bottom 2 images. These are post-contrast images.
So on the post-contrast images, I can see that there's central elements which don't show any enhancement, but there is surrounding enhancement, and I'm suspicious whether there's an element of pyonephrosis, pyometra going on in the patient who's previously...
Pyometra, when we say pyometra, we are talking about pus within uterine cavity.
Pyosalpinx.
Okay.
And also would fit with the clinical presentation of the patient.
Okay. So this is, you have rightly said that this is showing signs of infection, but this is not quite a pyosalpinx. You cannot differentiate the tube and ovary here. You can see a complex multiloculated cystic mass in the adnexa, in the pelvis, which is showing significant enhancement. You cannot separately differentiate the ovary and tube. And so this is a tubo-ovarian abscess. So what happened was, in the interval period, the patient had an attempted aspiration of one of the endometrioma, and then she developed superadded infection. So this is a tubo-ovarian abscess. Chapman gives differential for multilocular cystic lesion. These are the differentials. And the history and the intensity of enhancement and fat stranding and fluid would point to a diagnosis of tubo-ovarian abscess. So that takes us to pelvic inflammatory disease. So pelvic inflammatory disease actually is a broad spectrum of infection and inflammation affecting the female genital tract. Most commonly, it's an ascending infection, starts from the vagina, and with the cervicitis, endometritis, salpingitis, or ophoritis, results in pyosalpinx or a tubo-ovarian abscess. It can result in complications, most commonly impaired tubal function, obstruction, hydrosalpinx, and infertility. The abscess can rupture and cause peritonitis. It can cause extensive peritoneal adhesions, and which can result in bowel obstruction. Other complications include ovarian vein thrombosis or thrombophlebitis and Fitzhugh-Curtis syndrome. So candidate 5, you've done the whole of endometriosis, didn't you?
Yes.
So maybe, thank you very much. So maybe we can have the next candidate, please. So do we have the next candidate here?
Hello.
Candidate 6?
Yes.
Oh, hi. Yeah, so this is the case for you.
Okay, so I can see large bilateral pelvic cystic lesions. They are hypointense on T1, hyperintense on T2, and hypointense on fat-saturated T1. On coronal, I can see that on the left side, it is of convoluted appearance.
Good.
Given acute pelvic pain, there is a thick enhancing, uniformly enhancing rim of both bilateral adnexal lesions. I'd like to check the diffusion weighted images, but my primary diagnosis would be bilateral PID with pyosalpinx on the left side.
Okay, brilliant. Yeah, good. So this is, I've chosen this mainly to see the pyosalpinx. So this is the typical convoluted tubular appearance with of pyosalpinx. You say pyosalpinx when you see that intense enhancement of the surrounding wall. So without the wall enhancement, you would call it hydrosalpinx. So this is PID again. Okay, good. So pyosalpinx on ultrasound, you will again see it as a tubular structure which may have internal echoes or maybe a fluid level. There are longitudinal folds within the tube. So these get thickened due to inflammation. So on a true cross section, you will see a pattern which is similar to a cogwheel because of the thickened longitudinal folds. So this is a cogwheel sign or a beads on a string sign. Okay. So CT in PID. Most often these patients in acute pain end up on an ultrasound list or on your CT hot list. So it is important to be aware of the findings of PID on a CT. So this is a normal appearance where you can see clear flat pelvic fat. There is no fat stranding. And these structures which we have pointed are paired uterosacral ligaments. So these are normal structures which connect the lower segment of uterus to the mid-sacrum. So what happens when there is cervicitis or endometritis? The inflammation spreads posteriorly and you can see thickening of the uterosacral ligaments. Okay, so the other findings include extensive pelvic fat stranding, there can be free fluid, loss of facial planes, loss of definition of uterine contours, you may get peritoneal enhancement and engorged ovaries. Okay, so these are the features of uncomplicated pelvic inflammatory disease. Now, candidate 5, tackle this case now, please.
Okay, so these are axial and coronal CT with contrast of the abdomen pelvis, aneal and pelvic. So the most striking finding I can see is on the top right corner image. I can see that the right ovarian vein is markedly distended with a large central filling defect.
Good.
And this, the lower image also confirms this in a longitudinal section.
Good. So what's the diagnosis?
Yeah, so it's right ovarian vein thrombosis.
Why? What is the cause?
I'm searching for the abnormalities in the pelvis. I can see fat stranding in the, yes, in this image and the one below in the pelvis.
Good. So yes, and maybe we can say there is mild thickening of the uterosacral ligaments. So there is fat stranding. So ovarian vein thrombosis as a complication of PID has been asked repeatedly in the exam. It is an important case for your viva as well. Something which you need to remember is, in cases of PID, you can get enlarged, it's not shown in this case, but you need to be aware that you can get enlarged para-aortic lymph nodes at the level of renal hilum. This is because the lymphatics and the lymphatics draining the ovary and the tubes, they drain alongside the ovarian vein, which open at the level of renal hilum. So in the pelvic inflammatory disease, you can get enlarged para-aortic lymph nodes at the level of renal hilum. So I think we are really short of time, so I'm just taking over. I'm going through the case myself. So we can see pelvic inflammatory disease, fat stranding, fluid. So there is pelvic inflammatory disease. So this lady or this person presented with, this is a case from the online resource, Radiopedia, I think. So this lady presented with acute onset of right upper quadrant pain and with a background of pelvic inflammatory disease. And when you image, if you see focal enhancement of the liver capsule, then that is in keeping with Fitzhugh-Curtis syndrome. So it is nothing but ascending infection and direct intraperitoneal seeding in the perihepatic regions. It's also called perihepatitis. So there will be subtle adjacent or more prominent adjacent fat stranding and fluid in the perihepatic region or in the pelvis. I'm not aware whether this has been asked, although uncommon. This is a recognized complication of pelvic inflammatory disease, so just be aware of the finding. The clue is focal capsular enhancement of liver with adjacent fat stranding or fluid. Okay. Yes, this is the next case.
Okay, so cystic mass on ultrasound for characterization. I can see a large central pelvic lesion that's situated between the ram bladder and the rectosigmoid. I can see the parametrium is coming off the lesion on the left side. It's of low signal on T1, high signal on T2, and it suppresses on fat suppressed sequences.
I did not quite get what you were pointing at. I mean, unfortunately. Okay, let's start with the T1. I'm showing it. So this is a T1 low signal pelvic lesion.
Yes, and it's high signal fluid signal on T2.
T2.
And
What can we see on T2?
Sorry, what can I see?
What else can we see on T2?
Maybe there is a solid component inside the cyst.
Yeah, there is a incidence or a solid soft tissue component.
Yes.
And
that's, yeah, this is fat suppressed T1. The lesion, the fluid component suppresses.
We compare the T1 with the T1 fat suppressed. So the fluid is low and fluid remains low.
Yeah.
So there is no fat here.
Yeah, I said it's a fat suppressed sequence.
Okay. So I thought you were saying. I thought you meant there is fat suppression. Okay. No. Yeah. Go on. Yeah. Sorry. Go on.
Okay. So here it appears to be connected to the broad ligament in the coronal image, and on the sagittal, nothing new on the sagittal. Maybe a little bit of stranding anteriorly.
Okay.
Or irregularity related to the anterior margin of the lesion. And there is enhancement of the solid component on the post-contrast image.
Okay, so when you see a cystic lesion with solid component with enhancement, what is your diagnosis?
Cystic ovarian neoplasm.
Yes, this is a CA of ovary. So when you see solid component in an adnexal lesion with enhancement, so malignancy is your number one consideration. Okay, so Chapman has given the differentials like this. The TUS tumors, malignant tumors, are mostly mixed solid cystic lesions, and the most common types are the epithelial ovarian tumors. We are not going into any detail of the how to differentiate the subtypes. We are keeping it at 2B level, but it's important to know that serous tumors, serous carcinomas, serous cystadenocarcinomas tend to be bilateral and have calcification. So clear cell and endometrioid cancers can develop in a endometrioma. Okay, so the classification goes again like mainly solid lesion, not T2 hypointense, and bilateral adnexal lesions. We will be covering most of the highlighted ones, the yellow highlighted ones. So that brings us to the staging of ovarian CA. Stage 1 is limited to the ovaries. Stage 2, it involves the pelvic structures. In stage 3, there will be extension outside pelvis or retroperitoneal adenopathy. So you get peritoneal metastasis outside the pelvis and retroperitoneal adenopathy. So in stage 4, you get distal metastasis. Okay. So these are the sequences that we take. Essentially, again, T2 in 3 planes. Then we have a T1 fat saturated, and then pre and post contrast enhanced sequences. So this is a table given in your Chapman with an approach to ultrasound and MRI to the adnexal lesions, essentially classifying it as benign, malignant, and indeterminate lesions. So essentially what we see is if there is a lesion which shows solid components papillary processes and intense enhancement, then you are dealing with a malignant lesion. So here we have a complex mixed cystic solid lesion in the pelvis, which is showing enhancement. So we are looking at a malignant ovarian mass. Now, can you describe the CT findings?
Okay, so on CT, I can see large pelvic abdominal ascites. I can see scalloping of the liver surface, most noted on the left lobe.
Good.
I can see also peritoneal thickening, parietal peritoneal thickening.
Good.
As well as some masses.
What does this liver scalloping mean?
It's pseudomyxoma peritonei.
That's very good.
The amyocinous tumor.
Good, excellent. So this is already metastasized to the peritoneum with omental cake. So it's already a stage 3 disease. And pseudomyxoma peritonei occur when there is gelatinous or thick mucinous ascites. So there will be scalloping of the surfaces, visceral surfaces. Most commonly, this is due to a mucinous tumor of appendix, but other tumors, mucinous tumors of GI tract and ovaries can also cause this. So this is a lesion, adnexal lesion, which is of low signal or intermediate signal on T1, intermediate to bright on T2, and it stays bright on the fat saturated image. So this is a cyst with hemorrhage. We can see focal high signal foci within the lesion, which is of low signal on T1 and T1 fat suppressed, but it enhances on contrast enhanced images. You can see this is a cyst with hemorrhage with an enhancing solid nodule. So this again is CA ovary. And the histology showed it to be an endometrioid type of tumor. So because of shortage of time, I'm just going through the cases at a faster pace. So in this case, the patient has extensive peritoneal metastasis. You can see omental caking, extensive pelvic nodularity. You can see a multiseptate cystic structure in the left adnexa. It's probably arising from the left ovary, but on CT, you're not seeing definite malignant features, but you can see extensive nodularity in the pelvis. It's on the serosal surfaces of the bowel. A follow-up MRI scan again showed the same. By then there is some ascites as well, extensive nodularity. So this is peritoneal carcinomatosis. You can see a beautiful serosal deposit on the undersurface of sigmoid. Okay, and so this is peritoneal carcinomatosis and thought to be from a ovarian primary. GI malignancies also can cause similar appearance, and histology confirmed metastatic CA ovary. So just wanted to show you this appearance. Remember, in endometriosis we had the mushroom cap sign, and this again will look similar to the endometriotic deposit, except that the signal is completely different. The plaque is very low signal on T2, whereas the metastatic deposits will be of intermediate or soft tissue signal on T2. And there will be other signs of metastasis, whereas here you will see other signs of endometriosis. This is a complex cystic lesion with looks like some hemorrhagic component. It shows internal vascularity. So on MRI, it does show, this is a T1 fat saturated sequence. No, this is a T2. This is a T2. This is T1 fat saturated. So it does show some hemorrhagic content. It does show a solid nodule on T2, but following contrast, there is not much of enhancement. There is no enhancement at all. So at this stage, it did not demonstrate definite signs of malignancy, and she was kept under close interval follow-up. After 6 months, it just blew up. So it has now become a full-blown malignancy with a multiseptate cystic mass with enhancing solid components. So what I wanted to show you was, in this multiseptate, multilocular cystic structure, cystic mass, you can see some variations in the T2 signal. So this is not as hyperintense as the rest of the cystic component. So this is something that you can see with mucinous tumors. The different locules may have different protein content and may show different signals on T2. So this is also called a ground glass staining sign.
Yeah.
Candidate number 5 or candidate 6 is with us?
Yes, 6, I'm with you.
Oh, hi. Patient has history of CA colon for which right hemicolectomy was done. Now presents with acute abdomen. So I've given you serial coronal sequence portal venous phase.
Okay, so I can see multiple dilated small bowel loops, as well as descending colon. This is in keeping most of it intestinal obstruction.
Good.
I'm trying to pinpoint the cause, which is possibly in the pelvis.
What am I pointing at?
Yeah, it's a large pelvic cystic solid, complex cystic solid mass.
Mm-hmm.
Yes, and mostly it's the reason for the intestinal obstruction, maybe peritoneal deposits or adhesions, or
Good.
maybe a volvulus happened around it. Not sure.
Maybe we have the reasons for the bowel obstruction in front of us. This patient has a background of CA colon, isn't it? So when you see with a background of CA, when you see bilateral adnexal tumors like this, which are looking aggressive, malignant looking tumors, so what do you think? What do you suspect these are?
Krukenberg tumors.
Krukenberg tumors, yeah, and Krukenberg tumors are metastasis to ovary, and the most common from GI malignancy. And additionally, we can see a peritoneal omental deposit here. So the bowel obstruction is because of peritoneal involvement by the metastatic lesions. Okay, adhesions or direct involvement by the metastasis. So this slide was to show you Krukenberg tumors. It would look similar to any other ovarian tumor. It's with the background history of a known malignancy that we diagnose Krukenberg tumors. So Chapman gives the differential for bilateral adnexal lesions, which are as follows. Okay, we have covered the highlighted ones anyway. So this is for completion's sake. This is an ovarian fibroma. So it is a fibrostroma-rich ovarian tumor, which will look similar to a uterine fibroid. So it will be low signal on T2, intermediate to low on T1, variable enhancement. So it is almost always a benign tumor. Okay, so and when it is associated with pleural effusion or ascites, we call it the Meigs syndrome. So this is just for you to, for completion's sake that I've added. The main differential is a broad ligament fibroid or a pedunculated serosal fibroid. Yeah, this is a 10-year-old child with intermittent severe lower abdominal pain. Describe the findings.
Okay, I can see large complex cystic lesion centered in the pelvis of low signal intensity on T1, of high signal intensity on T2.
Mm-hmm.
I can see the ovary with small follicles is stretched around the lesion.
Good.
So it is mostly of an ovarian origin.
Good.
On the post-contrast images, I can see peripheral enhancement of the ovary itself, but no enhancing solid component.
This is a pre-contrast image, and this is the post-contrast image.
Mm-hmm.
Can you see any enhancement?
Not really. Maybe outside.
Yeah, outside the ovary, there we can see enhancement. So that shows this is a post-contrast, but the lesion as such does not show any enhancement. So with the history, with this appearance, what is your diagnosis?
So given the intermittent history of pain, maybe it's some sort of benign tumor, or it's not blood density, so I'm not suspecting any obstructive congenital anomaly.
Remember, there is no enhancement. If it's a benign or malignant tumor, you expect it to enhance.
Not really sure.
Okay. So this is adnexal torsion, ovarian torsion. Okay. So ovarian torsion can present as an acute, can present acutely, or it can have chronic intermittent partial torsion. So what happens is, when the ovary undergoes torsion, it becomes edematous, it enlarges to a great extent, and so it can have bizarre appearance, it can have cystic changes, hemorrhagic changes. Classically, we'll see that when the ovary is enlarged, the ovarian follicles are stretched and are seen at the periphery of the lesion. So that is a clue that this is an enlarged ovary. Okay, on this image, on this case, it's difficult to say if there is an underlying mass lesion or if the entire change is because of hemorrhagic or cystic changes. But the fact that it does not enhance, even the normal ovarian parenchyma here does not enhance, is worrying because the vascularity is compromised. So in acute torsion, typically the follicles are peripheral. You can see a twisted pedicle sometimes. It will be free fluid. On ultrasound, you may or may not demonstrate color flow. Now, chronic torsion or chronic or partial or intermittent torsion is another entity where the patient presents with acute pain and then they'll be all right. The same happens again. And so as a result of this, the ovary again enlarges. There will be massive ovarian edema. Usually you will have Doppler flow. Okay. So this is an image of ovarian torsion. Now, can you describe the finding? I can say that just for you to know, there is a large ovary on one side, and incidentally, the other ovary has a cyst and shows normal follicles. So describe this large lesion, which is the actually torted ovary.
So the torted ovary is markedly enlarged, oval in shape, with high signal on T2, maybe signifying edema or congestion. I can see on the sagittal T2 image there are thin peripherally situated cysts, small cysts.
What are they?
They are mostly follicles.
Yeah, these are the peripherally situated follicles with the enlarged ovary, extremely edematous, peripherally situated follicles. So this is massive ovarian edema. And on T1, you can actually see, describe the T1 and fat saturated, please.
Yeah, there is a hyperintense ring for surrounding the ovary, or at the external surface of the ovary. But the ovary fails to considerably enhance post-contrast.
We don't have it. That's a fat saturated sequence.
Just fat saturated, all right.
Okay, so that again shows some high signal. So that means it does have some hemorrhagic element into it. So this is the appearance of ovarian torsion. So the giveaway or the clue is, look at the follicles where it is positioned. So an enlarged ovary without a dominant mass, which appears extremely edematous, with peripheral positioning of the follicles, and with the history, think of ovarian torsion. Okay, so on an ultrasound again, you can see that the ovary is enlarged. Look at the size given of the torted ovary and the normal ovary here. The follicles are all situated in the periphery. The main center is echogenic edematous and there is no blood flow. So these are the differentials. Unilateral enlarged ovary without any dominant mass, the differential, it's always torsion, either acute or chronic intermittent partial. So you may be given cases, when the examiner gives you case, they'll give a short history. So from my experience, what I know is the examiners do not waste words. So the short history, however short it may be, that may be a clue that can guide you to the diagnosis. So Chapman actually summarizes the different pathologies based on the presenting symptoms. So it's good to be aware of the presenting features in various pathologies. Okay. Okay, now shall we go back to candidate 1 again, please? Thank you, candidate 6. So shall we have candidate 1 back again? Candidate 1, can you hear me?
Hello.
Hello. So, hi. So this is a 27-year-old female presented with sudden onset of abdominal pain, tenderness and guarding. Urine beta-HCG or urine pregnancy was positive. That's a very giveaway, easy history. So but then describe the findings, please.
Okay, so there's widespread free fluid with an impression of hyperdensity. So I'm concerned that that's hemoperitoneum, and in the left adnexal region there is a hyperenhanced cystic lesion with hyperenhancing thickened rim, which you would imagine could be like a rim of fire kind of appearance. And if there was no evidence of an intrauterine pregnancy, then this is highly suspicious for a ruptured ectopic.
That's good. Yeah.
And I would urgently call the gynae.
Good. Yeah. So this is a ruptured ectopic, and you rightly said there is hemoperitoneum, high density fluid, and there is a cystic left adnexal lesion with a thick hyperdense surrounding wall. And if you see the hemoperitoneum, it's more denser surrounding that adnexal lesion. So that is a sentinel clot or a hematoma there. And so the history is very important. In a reproductive age female who presents with similar acute abdomen, hemoperitoneum, adnexal lesion, and in the absence of an intrauterine gestational sac and with positive uterine pregnancy test, this is the number 1 concern. So what are the signs? Yes, raised beta-HCG has to be there. It can present as an adnexal cyst. Most commonly it's a complex cyst. It will be vascular. On ultrasound, you can see it as a complex lesion which is vascular, which can again have the tubal ring sign. There is the tubal ring sign is described next to the normal ovary. You can see a small cyst with echogenic wall. So this is ectopic pregnancy within the tube. So this is called tubal ring sign. Okay, if you're detecting fetal parts or fetal cardiac activity, then that is confirmatory. So the main differentials are these, and it's important to know that corpus luteum is the number 1 differential. So in the exam scenario, it may be a straightforward case with the history given to you and the images given to you. It may be a straightforward case of ruptured ectopic, but in real life, sometimes it can be really challenging to differentiate between the two. This is a 30-year-old female, markedly elevated beta-HCG. She presents with hyperemesis and bleeding PV.
So I'm given a single grayscale image of the uterus, and within the endometrial cavity there is a multicystic lesion. In the context of a markedly elevated beta-HCG and hyperemesis, I wonder whether this represents a molar pregnancy. I can't see a fetal pole or anything.
That's good. That's good. Very good. So this is molar pregnancy or a hydatidiform mole. So molar pregnancy, again, it happens. It's uncommon, and it's always the result of fertilization, which is abnormal fertilization. So it can be a complete molar pregnancy, and where the features that you've seen before, like the multicystic mass with the multiple echogenic mass with multiple cystic spaces within the uterus is seen, and you cannot identify, you cannot see any fetal parts. So this is a complete molar pregnancy. In a partial molar pregnancy, similar appearance, but you may see some fetal parts. So this is the appearance of a molar pregnancy on CT. Unlikely that you will be shown one. It will be confined to the uterus. It will be a vascular heterogeneous mass within the uterus. So this appearance is called, on ultrasound, this appearance is called a bunch of grape appearance or a snowstorm appearance. Okay, and what happens because of the high level of circulating human gonadotropin, so that can have effects on the ovaries, and the ovaries develop bilateral theca lutein cysts. So this bilateral theca lutein cysts you can see with all types of molar pregnancy, including invasive mole and chorionic carcinoma. So this is a partial mole where you can detect some fetal parts as well. If given the diagnosis, this is a choriocarcinoma. Invasive mole also would look like this. So can you describe the findings?
So there are bilateral large adnexal cystic lesions with multiple thin septations that are enhancing, and
they are in this.
So they're the theca lutein,
bilateral theca lutein cysts.
And then within the there is a heterogeneous mass within the uterus that has got enhancing components and cystic components, but it's hyper enhancing on contrast imaging.
Okay.
So the features are consistent with a invasive.
Yeah, it does invade into the myometrium, and choriocarcinoma it behaves like any other malignancy. It can metastasize. So cannonball metastasis to lung is common in choriocarcinoma. And the next few images are about for us to familiarize with how normal post-cesarean section uterus look like. It's not uncommon for an acute abdomen post C-section to land on your CT urgent list. So it's important to be familiar with the normal findings of a post C-section abdomen. So that is mainly involving the lower uterine incision, endometrial cavity, and what is called the bladder flap hematoma. So on an ultrasound, the immediate post-op, the lower segment cesarean scar would look oval in shape, hypoechoic. This is because of edema. When we go on the transverse view, we can see multiple tiny dot and curvilinear echoes, which represents the suture material. So this is a normal post-op appearance because of edema. And on CT, this is the incision, which will look hypodense. It will look as if the myometrium is discontinuous, but this appearance is because of edema. You expect some amount of thickening or contents of fluid within the endometrium. There will be some hyperdense blood clots within the endometrium. Importantly, look at this isodense soft tissue structure between uterus and bladder. This is called a bladder flap hematoma. Now, it is common to get a bladder flap hematoma when there is a lower section wound here. It is common for it to bleed and form a small hematoma here. But it's important that it is less than 4 centimeter. So less than 4 centimeter, it is not significant. But if it is more than 4 centimeter, more than 4 to 5 centimeter, then we are worried about uterine wound dehiscence or rupture. So these are the complications of cesarean section, endometritis being the common, and these are the other complications. Now, can you describe the findings on the CT scan, please? It's a third post C-section day.
Okay, so I've got sagittal, a single-size sagittal section of a 3-day post C-section with severe abdo pain and fever. Within the uterus, the endometrial cavity, there are locules of gas, and also within the area of the lower uterine segment scar, there are also locules of gas that are extending anteriorly. And I would want to just rule out that the large locules of gas anteriorly are not within bowel loops, but it doesn't look like there's any kind of enhancement. So I've got free fluid and gas in a patient that's febrile, and I'm concerned that they've got a infected hematoma. It's probably, I can't measure it obviously, but if it was greater than 4 centimeters, then it would be too large for a bladder flap hematoma, and so this could be an infected hematoma.
Yes. So when you said if it's more than 4 centimeter, it's too large for it to be a bladder flap hematoma. So bladder flap hematomas, if what I meant by in my previous slide is, if a bladder flap hematoma is more than 4 centimeter or 5 centimeter in size, then it is significant. Less than 4 centimeter, it's not significant. I didn't mean that it cannot be more than 4 centimeter. Okay?
Oh, okay.
Okay, yeah, so you rightly said this is infection. So there is evidence of, there is a lot of overlap between the normal post C-section finding, because the endometrial cavity can have some amount of air in it, can have some high density or contents within it. But this appearance is abnormal. So there is air throughout the lower uterine wound, which is contiguous with the anterior collection, which is showing an air fluid level. So this is an abscess. This could be an infected bladder flap hematoma. And this appearance, it is concerning for uterine wound dehiscence or rupture with a collection and with endometritis. Okay, so just to let you know the difference between a uterine dehiscence and rupture. In dehiscence, what we mean is it is incomplete rupture of uterine wall. Okay, the myometrium would look discontinuous, but the outermost serosal lining, which will look like this, it will look hypointense. Okay, that will remain intact. So if the outermost serosal lining is intact, then that is uterine dehiscence. So this is a huge bladder flap hematoma, which is contiguous with the uterine wound, and the serosa is intact. So this is uterine dehiscence. So if the serosa is disrupted, then it becomes rupture. And of course, MRI is superior to CT to differentiate the two. Yeah, persistent postpartum bleeding.
Okay, so I have got sagittal and axial views of the postpartum uterus, and within the endometrial cavity, I've got hyperechoic material that demonstrates blood flow within it on the Doppler images. This is highly suspicious for retained products of conception, or retained placenta.
I'm sorry, what did you say?
A bit of retained placenta or retained products.
Okay, yeah, good.
Post,
so again, in retained, when you diagnose retained product of conception, there is again a little bit of overlap between normal findings, normal postpartum or post C-section finding. We do expect hyperechoic contents within the uterine cavity in the postpartum or post C-section period because of blood clots. But if you demonstrate blood flow within it, then you can diagnose it as retained products of conception. So this is the MRI image. Can you describe the findings? I have not given post contrast images. I have a T1 fat sat and T2 images. Describe the findings, please.
So on the T1 images, I don't have great spatial resolution of soft tissues as expected, so I won't dwell on that too much. But within the T2, there is heterogeneous and hyper-intense signal on the T2, which is not suppressed on, well, that would be relevant on T1 anyway, but yeah, there's no fat suppression anyway. So I think these are,
This is the same case as the ultrasound that you described.
Yeah. So I should be expecting kind of blood products and cystic components, which would be consistent with what I'm seeing, in the sense that I've got hypo intense on T1, hyper intense on T2, with no fat suppression of the hyperintense areas. So there's hemorrhagic components within it, and we don't have post-contrast imaging, so I can't ascertain whether there is.
Yeah, good. So we've already seen it's got blood flow within in the ultrasound. So this is a retained product of conception. But then, yes, again, you do need to demonstrate the vascularity to confirm it. Look at the T2 image here. Is there anything else that you would like to add?
Has she got a rudimentary horn? I don't know whether I've got that in my head from the beginning.
Yeah, it might not be a rudimentary horn, or it could be a partial.
So the cirrhosis is intact, so it could be a dehiscence of the lower uterus.
No, we're not going into the rupture or
okay.
the territory. No, we are looking at what you said initially was correct. You thought there might be a rudimentary horn. What I meant is this could be a rudimentary horn, or it could be a partial biconvate uterus. You can see there is a dip here, and then this was a pregnancy happening in one of the horns of a partial biconvate uterus.
Oh wow.
Okay, and so yeah, I think that was the last slide of this session.
Thank you so much. Thank you.
Thank you very much, and I hope this has been useful and it will help you with your exam preparations. Thank you very much, and please don't forget your feedbacks. Thank you.
Thank you very much.